It's a great opportunity to be here. I'm going to talk about treatment strategies in left main coronary disease associated with acute coronary syndrome. The acute coronary syndrome is a different ball game, particularly when you have a left main disease associated with this. And Dr. Das mentioned the controversies of left main disease treatment with a bypass or PCI in stable coronary disease. I'm going to talk about patients with acute coronary syndrome. Now, it's a difficult situation, but at least in acute coronary syndromes, the pathways are more clearer. Let me take you through an example of a patient who I encountered last week. Young man, middle of night, comes with acute coronary syndrome, chest pain, ST elevation, cardiogenic shock, and we did an angio, found his left main was completely occluded. This patient was taken for PCI with ILP support. He fortunately survived. And this is an example of how this treatment strategies becomes very clear when patients present with acute coronary syndrome or cardiogenic shock with ST elevation MI. Now, over the next 8 minutes, I'm going to talk about the incidence of left main disease and acute coronary syndrome, the clinical and anatomical characteristics, the outcome of these patients, and I'm going to conclude with the final statement. Now, all this about in patients with acute coronary syndrome, the data is less clear. We don't have randomized studies comparing treatment strategies in acute coronary syndrome, left with the bypass or CABG. Most of the data comes from the registries. The most important of these registries is the GRACE registry. This was published in 2009. In GRACE registry, the incidence of left main disease in patients with acute coronary syndrome was 4%. As you know, the GRACE registry, patients were triaged with left main disease to a PCI arm, a bypass surgery arm, and a conservative treatment arm. A majority of patients did also have ST elevation MI in the GRACE registry also. The next important registry is the AMIS registry, acute myocardial infarction, Switzerland. This is published again in 2010. This compared left main PCI versus non-left main PCI. The patients were presented with ST elevation MI, primary PCI were triaged into the primary left main PCI arm and the non-left main PCI arm, and they found that the incidence of left main PCI was about 5.2%. Now, the incidence of left main lesions at coronary angio is about 10%. Left main lesion is an important factor of negative prognostic connotation. Incidence of acute left main occlusion in acute coronary syndrome, patients about 0.8%. Incidence of left main lesions in acute coronary syndrome, patients about 4%. Now, patient acute coronary syndrome and left main lesions have more complications. That cardiogenic shock is about 12% versus 3.5% who present with non-left main lesions. Cardiorespiratory arrest is about 10.6% versus 6.3%, and patients tend to have more severe arrhythmias. The global mortality rates in patients who present left main lesion, acute coronary syndrome, is about 7.7%. ST elevation MI, the mortality rate is 11%, and cardiogenic shock is about 34%. Now, if you look at the GRACE registry, the patients who are recruited in the GRACE registry, ST elevation MI was around 627 patients, and they were triaged into the PCI arm and the bypass surgery arm. If you look at the AMIS registry also, ST elevation MI comprised about 348 patients, and the cardiogenic shock was about 12% in those particular registry. If you look at the AMIS registry, if you look at the patients who presented in the AMIS registry, majority of patients who were triaged to the PCI arm were the left main PCI arm had more history of resuscitation prior to admission, cardiogenic shock at admission, more dyspnea, more use of intra-aortic balloon pump, and more use of vasopressors. If you look at the NCDR registry, about patients who present with unprotected left main and ST elevation MI, the incidence of cardiogenic shock was about 60% compared to patients with non-ST elevation MI, the cardiogenic shock was only 30%. If you look at the GRACE registry, the in-hospital mortality of PCI was 11%, and the AMIS registry, the in-hospital mortality was 11%. This goes on to say that patients who present with left main disease have more severe disease and have more complications as far as cardiogenic shock or other complications are concerned. This is a small study. We looked at 48 patients present with ST elevation MI and non-ST elevation MI, and they found that the location of distal disease was more in the distal left main compared to the ostium or the proximal body of the left main. This makes the whole thing more complicated. If you look at the GRACE registry, patients who were triaged to the PCI arm were elderly patients about 75 years of age, had a new onset ST elevation and left bundle branch block. Majority of them were in class 3 or 4, and majority of the patients had cardiogenic shock also. This goes on to say the patients who were triaged to the PCI arm had more severe disease and were presented in a severe situation. If you look at the HyBiz registry also, if you look at in-hospital death of patients who presented with acute coronary syndrome and who were in the GRACE registry, patients who had in-hospital death, the cardiogenic shock and death also was more in the patients who were triaged to the PCI arm. Whereas if you look at the HyBiz registry, patients who are triaged to the in the left main category, unprotected left main category, in-hospital death was about 10.9% compared to 3.8% in the non-left main PCI arm. Death and MACE were significantly more in the unprotected left main PCI arm compared to the non-left main PCI arm. In-hospital death, if you look at unprotected left main and a combination of other vessel PCI, the complications more in the in-hospital, in the unprotected left main and other vessel compared to unprotected left main PCI alone. If you look at in-hospital death in elderly patients above 75 years, the in-hospital death, the MACE and shock was significantly more in patients who are unprotected left main PCI and age above 75 years. So what are the independent predictors of in-hospital mortality? Cardiogenic shock at admission, history of resuscitation, a Charlson score of more than 2, and left main treated disease, and age per 1 year increase, heart rate and systolic blood pressure were independent predictors of mortality in this particular HyBiz registry. If you look at patients who present acute left main ST elevation MI, the mortality, whatever happens, is in the first 30 days. There is a 5-fold increase in mortality in patients who have left main ST elevation MI compared to non-left main ST elevation MI. But after 30 days, it tends to even out. Most of them have the same course if you compare left main PCI and non-left main PCI. If you look at cardiogenic shock representation, if you have a cardiogenic shock representation, the mortality rates are significantly higher. Survival rates around 30% compared to patients who have no cardiogenic shock, a survival rate of about 80% at the end of 3 years. The NCTR registry also showed in-cath lab mortality and in-hospital mortality are significantly higher in patients who presented with ST elevation MI. Independent predictors of mortality was ST elevation MI with cardiogenic shock and use of IAVP, salvage PCI, and a pre-procedural TIMI flow of 0 and 1. Again, the data from the SCAR registry, Swedish registry also showed that patients who had triaged to the bypass surgery arm tend to favor better compared to the patients who had a PCI in the patients who presented with acute left main ST elevation MI. Now, if you look at there was a study by Prakriti Gaba, which is from the Brigham and Women's Hospital. They took off patients from the Syntax trial, the pre-combat trial, the Noble and the Excel trial, picked out patients who had acute coronary syndrome. They found the patients who had acute coronary syndrome tend to fare worse than patients who did not have acute coronary syndrome. So I just want to conclude by saying there's no recommendation in guidelines stating optimal revascularization methods in patients with left main lesions and acute coronary syndrome. There are few randomized studies and data from registries which show that in selected patients, left main PCI would be a better option than patients who present with bypass surgery. Let's go to the conclusion slide, please. Unprotected left main lesions are responsible for 4 to 6% acute coronary syndromes. 70% acute coronary syndrome lesions affect the distal left main. The preferred PCI strategy is provisional stenting. PCI is the current strategy for left main associated with ST elevation MI, particularly in case of cardiogenic shock. For non-ST elevation MI, CABG still remains the main alternative. In-hospital mortality for unprotected left main PCI varies between 8 and 40%, lower for non-ST elevation MI and higher for ST elevation MI. And the most important condition predicting in-hospital death or mortality is cardiogenic shock. And in-hospital mortality by isolated unprotected left main PCI is twofold the overall acute coronary syndrome mortality. It increased to 5-fold in cases of left main PCI associated with other coronary segments. And among survivors without cardiogenic shock, 1-year outcomes are similar to patients undergoing PCI for other vessels. Thank you very much for your patient hearing.
If with the permission of Chair, may I ask a question, sir? There have been two recent registries. One is the Egyptian and Ptolemy. Oh, okay.
Please be brief in your question.
Yeah, just a brief question. There's an optimal trial which says that deferred stenting in patients who present with acute left main occlusion. So they basically dilate the lesion, achieve a TIMI-3 flow, because achievement of TIMI-3 flow post-procedure carried the maximum benefit in left main stem lesions. So deferred stenting and fourth-day stenting these patients, this trial is still undergoing, and the belief is that putting a stent in an acute left main disease can be associated with more distal re-embolization and more reperfusion injuries. So what are your comments, the optimal trial?
I think you should look at every patient as an individual patient. If you think the patient has a huge thrombus load, it's better to defer stenting rather than do a stenting and end up with no reflow and a further complicated situation. I think every patient has to be taken as an individual
Cardiogenic shock,
patient.
unloading the patient and deferred stenting, these are the upcoming things which probably.
I have just one quick question for you and then we'll close this talk. See, the technique of doing left main angioplasty has evolved over the last 15, 17 years with considerable increase in the experience of the operators and all that. So has been the case also with the quality of the stents that are available today vis-a-vis they were 15 years ago. So do you think that over a period of time, the results of the left main bifurcation have changed in the setting of ACS, let's say, vis-a-vis a non-ACS situation?
Absolutely. I think with the use of imaging, with the use of better quality stents, and the outcomes of patients can be more predictable and better.
Because some of these data are not very recent, on the left main bifurcation or acute coronary syndrome, and they are a mixed bag of patients, that has been, reported over a period of time.
Right.
So one of the very recent data in 2023, the Egyptian registry and the Atolama registry, they found that using even the two-stent technique was equivalent and even the bifurcation techniques.
Okay, thank you. One final question is that do you think that you have an STEMI with an ACS, okay, and left main, what do you do?
I think the best thing is to take him to the lab and initiate.
You have to stent it because you can't do a CABG, anything.
There's
No surgeon will touch.
That's why I mentioned the first patient example
Exactly.
I mentioned.
Thank you.